So talking about critical care, it's kind of the service that defines emergency medicine, certainly in the eyes of the patient, because that's why they believe you're here. Is if they have a life-threatening condition, they know you know how to deal with it. You know, the TV show ER did great service for us. You know, frankly, we deliver far more primary care than we do critical care. Primary care kind of is what we do a whole lot of, but emergency medicine is what defines the value in the mind of the patient, and in many ways the mind of the payer too. So this is not a code. This is not a CPT code we get a lot of pushback from the payers on, saying, "Oh, I don't really think that was, you know, that patient wasn't critical." It's kind of like they leave that one alone. They'll fight over the level 5s. But this code, you know, we undervalue it. And certainly underreport it to a large extent. Of course, it pays more than a 5, and in cases where we failed to finish the system review, but I documented a critical care note, that trumps all the components of history and physical. So even if I only did a 5-organ exam on a level 5 patient, but I could reasonably document it as critical care, I get the full 6.4 RVUs rather than the down code to 3.4, or, you know, a 88% more RVU value than is a level 4. So it's a kind of a code that covers a multitude of documentation issues, but has a value way beyond that. I talked earlier about what's a reasonable expectation, but I would say that probably 1 out of 10 of your Medicare patients are getting reportable critical care. Not all of them are admitted. Some percentage, probably 5 to 10% of your critical cares will actually go home. And we'll talk about how this is possible, you know, and how that works. But anyway, so I showed you this data before, and we see over time we've reported more critical care. The national statistic, the national average in 2010 was up over 7% of all ED visits for Medicare. 7% of all ED visits for Medicare got reported as critical care, and I think it actually would be higher than that. But there is a new definition. It's not new. It's been around for 11 years, but we're still in the coding and billing community still getting comfortable with this. But the definition now is effectively a high probability of sudden clinically significant or life-threatening deterioration exists. High probability does not require unstable vital signs. Patient does not have to be in crisis. They simply have to have the high probability of significant or life-threatening deterioration. The word "or" is a bit of an operative here. Medicare does not use the word "or," CPT does, but we can argue that the possible loss of a limb is a reason for critical care management. That moving that patient off to the OR, getting that, say, that trimalleolar fracture that may actually, if we did nothing, may actually cost the patient their limb. Okay, because there's malalignment, and you know it's not going to get the blood flow there, and there may be neurovascular compromise and all the stuff you got to manage emergently to get it off to the OR so it can be pinned. Could reasonably, arguably, be called critical care because the patient could well lose their foot if we did nothing. That's the concept of critical care. I'll talk about that in a second. So the first level is high probability of clinically significant deterioration. Second is requires highest level of physician preparedness to intervene. There isn't anybody better prepared to intervene than you all. You're built that way. It's the way emergency medicine is constructed, to intervene urgently. So by definition, we meet the second criteria. And the third criteria is effectively, what if we did nothing? Critical care requires the direct personal management, the absence of which would likely result in sudden, clinically significant, or life-threatening deterioration to prevent further life-threatening deterioration. That's CPT's definition. So think about the patients who come in presenting with what looks like a real crisis, but when you are able to clear them, it works out to be they're going to be fine. We'll give the example of the rollover T-boned accident with a rollover, just a pretty spectacular crash. And a guy comes in boarded and collared, and an hour in or 45 minutes in, you've got the CT back, you've got the, you're able to clear him neurologically. The guy's probably going to be okay. Some bumps and bruises, but no significant, life-threatening condition. But on presentation, what was the high probability of life-threatening deterioration if we did nothing? Okay, mechanism of injury says through the roof. High probability, guy was lucky, right? So there are lots of cases that present like that. Patient who's found down at the mall, it's a scoop and run, it's a John Doe, we don't know the guy, he doesn't have any ID, bring him into the emergency department, and then, family member trails in after and says, oh yeah, just, he's a diabetic, you just got to get him his meds or he's a Dilantin, patient. You just got to get him some meds and he'll be fine. An hour later, he's fine. He's going home, several hours after several hours observation. But knowing what we knew on presentation, was there a high probability? We don't know why the guy was down. Was he septic? Was he, was it trauma? Was it, what was causing? We don't know. And it's implied and required a fair amount of workup to get there. And then family member came and said, it's not a big deal. Just get him the meds and then you work them out. And that's what happens. Well, the patient was critical for a period of time. And you'll find some number of your patients are like that are only critical for a short period of time, 15, 20, 25 minutes. But for that period of time, they were critical. So we're going to ask you to document critical care whenever it happens, even if it's less than 30 minutes. And we'll learn in a minute, 30 minutes is the threshold for which we can actually report critical care. But we're going to ask you to document critical care whenever it happens for any length of time that it happens. 15 minutes, 20 minutes. Tell us it was critical care. Because we want to show that we don't always and only do 30 minutes of critical care on every patient. Now, it's variable. Sometimes it's less, sometimes it's more. We want the charts to reflect that. So, when we have a critically ill patient, we want the physician to state the amount of time spent in attention to the patient to prevent deterioration. So, I don't know what your EPIC note shows, but it could be as simple as 30 to 40 minutes in support of prevention of neurologic deficit, or in order to rule out neurologic deficit, or in order to prevent deterioration or respiratory distress. 30 to 40 minutes, 40 to 50 minutes. It could be a very straightforward statement. Don't just talk about what you did, but why the patient was critical when you did it. Because I often see emergency physician notes that say the patient was critical and I did this while I was intubating and titrating the meds and so on and so on. Well, we can figure that all out from the record. What we really need you to say was, in your perception, in your experience of this patient, what was it that you felt was the critical care condition you were managing? Well, I didn't want them to go into renal crisis, or I didn't want them to go into cardiac arrest, or I didn't, so like on the cardiac arrhythmia, on the atrial fib patient with RVR, 30 to 40 minutes of critical care. It might have taken 3.5 hours to get the rate down and manage, but you weren't bedside. You weren't hanging with the patient the whole time. So it's 30, 40 minutes in order to prevent, what is it we're trying to prevent? Cardiac ischemia or whatever. So we state why the patient, what we were trying to prevent. Right?
Do you need to document that in conjunction? Can that whole reasoning why you're billing critical care time be in the whole course, not just at the bottom of it?
No, that's fine. No, exactly.
Critical care time.
I like to see it as a separate note because it kind of crystallizes. But if you talk about it in the ER course, that's great. If you're that discursive, if you're that specific about how you're managing and why and what you're worried about. If you're talking about what you're worried about, it'll be obvious, and you won't need what I'm saying. What I've found in my and I'll say the same thing about observation, is that what I found with my physicians often is they have a dictation style, the way they manage your patient. And so, you know, at 4 in the morning, I don't want to have to be thinking about how am I going to change my dictation for this patient. It's like, okay, I always do it this way. Boom, 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 done. Now I get to the bottom and I say, okay, this was a critical care patient, so now I'm going to add my critical care note. Or this was an observation patient, so now I'm going to add my observation care note. Because I want to crystallize, I want to distill and crystallize the relevant points of critical care or the relevant points of observation care in a single place that makes clear to everybody why I was doing critical care or why I was doing observation care. So that's why I suggested in that format. Do it whatever way you're comfortable with. But just recognize the payer will always be asking, was this patient really critical? And often not with a sympathetic viewpoint. You know, again, like I said before, this doesn't happen a lot that we get challenged on critical care. But when we do, I want the record to reflect it, what you were concerned about.
And do we have to initiate saying that critical care was done, or can coders pull that out of the course?
You have to say it. Okay. Very specific language.
Well, yeah.
Yeah. Right, but there are some cases, now it's a great point, because there are some cases that are just so obviously critical care. It's like who could look at that and not say that, the patient wasn't critical. But you need to invoke the critical care concept. Yeah.
I thought the last time that we talked about this, and maybe I don't recall, I knew procedures were excluded from this, but I thought at that point we said that additional time spent performing additional documentation, reviewing of old records, and all of that would also be...
Oh, it does.
Okay.
Oh, yeah, yeah. Yeah, this is only time spent performing procedures, like 30 minutes of CPR and then we call the case. I don't have any critical care left to bill on that, because the guy was only alive 30 minutes and it was all CPR time. Right. So I don't really give up a whole lot because I'm going to get my level 5 anyway, plus my CPR that pays really well. So I'm not, like losing a whole bunch here. I lose a little bit on the critical care difference between a 5 and a critical care, but that's a minor issue. And you do your own math on that. Somebody's calling you? It is. It's calling. Somebody's calling you. Just ignore it. Yeah. Or,
no. This should be ignored.
Or just say no thanks. Yeah. Right. Yeah. Hit it. That's it. That's it. That they found you. So your intubation time, your time to do central lines, repair lac. You know how much time that took. No one else can infer it. I mean, we don't know. So you have to do the math and then, document it appropriately. And Epic probably has something like that built into its critical care statement that says, excluding time spent performing separately reportable procedures. So, yeah.
CPR, when we have a patient like that, under our procedures, we would do our procedure note for an intubation, a central line. Should we also do a CPR procedure note?
Yeah. Yeah, there's not much to say about CPR, except that it was performed. Saying things like ACLS protocol was observed, not there. ACLS protocol can mean pharmacologic attempt to convert, which is not CPR. CPR is the manual compressions, pumping the blue bag and thumping the chest. That's CPR. So ACLS protocols, okay, go ahead and say that. But then add that CPR was also performed. And it's best if you say CPR was performed in my presence. Not the entire time, because you're running in and out, but you're supervising the CPR. What we don't want the record to look like is CPR was performed in progress, okay, like out in the rig, but I don't know whether it continued in the ED. No, we want it to be clear, in my presence. So, anyway, is it me? Oh, it is me. You guys all looking around saying, does he not know? Thank you. Right. It was just an odd sound anyway. It's like, what was that? Payment begins at the 30th minute and then for every half hour after the first hour and 15 minutes. So the first half is free, but you get paid for a full hour for having only done half of it. And then you only get paid for, and then you get paid for an additional half hour after you've done 15 minutes of that additional half hour. So anyway, so I said consider the medical necessity statement to justify the critical care. So you know, here's a finely tuned medical necessity statement. What organs at risk? You know, the what and why of the diagnosis, your imaging, any EKG findings, ED course, and so forth. But that can all be distilled in a templated note like this, and what I'll call a phrase that pays. It's a templated note that says basically the blue is what goes in the template, and then we make patient specific this language, right? So critical care of X minutes. I always recommend a range because it's not possible to do a stopwatch on your critical care time. It's not. It's not about where you were physically. There's no way, there's no proxy for this. I can't put a little GPS device on your shoulder and you're in with the patient, a little barcode reader on your coat. Oh yeah, now I'm in with the patient and the clock is ticking and now I'm away from the patient. The clock has stopped because it's not positional. It's where your head is, not where you are. Okay, so 85% of critical care is done away from the bed. It's done while you're at the nurse's station. That's why you're looking up, you know, traditional Chinese medicine in combination with this presenting problem. I mean, with this medication you want to give them. You know, is there an interaction? Or you're talking to the CDC. You know, or you're going on the web. You know, to like check the poison index. Yeah, all the stuff, the PDR, and all the stuff you do away from the bed is all critical care time. It's anything you do giving attention to that patient while they're critically ill. So I want to give a range of time. You can't know, no one can know exactly how long it was. So you give your subjective range of time, 30 to 40 minutes, performed in order to assess and manage the high likelihood of life-threatening neurologic decline, or whatever your life-threatening cardiac ischemia, or life-threatening whatever it is you're concerned about, respiratory distress. What are you trying to prevent? Okay. Then let's talk about what I did. Did I order a CT showing you know, that's an obvious subdural hematoma with TPA considerations. Okay, well, maybe it didn't. I ordered a CT. I ordered a head CT with TPA considerations without, you know, diagnostic certainty or something, you know, something that you want to say, all right, here's what I did. But let's recognize that part of what I did was, even if I didn't do any procedures, with frequent assessment, is that what we do with critical care patients? Absolutely. Even if you don't go back in and see them constantly, you will go back in and see them, I trust, you know, more than once or twice throughout their, you know, hour or 2 or 3 hour stay. You're going to go back and see them. You're going to assess them not only at bedside, that's not even half of the reassessments that you do. You look at the nursing notes, you're checking the monitors, you're kind of moving around the department. Oh, how's she doing over there? You know, I'm a little worried about the, you know, I can see the rhythm is starting to go up. I better get back over there. Those are your reassessments. That's critical care management. It's not physical intervention, let's give them a high-powered med. No, it's let's try not to give them the high-powered med. The example is in the coding conferences that we go to. You know, in the last several years, presenters have tried to say, oh, unless the physician gives a high-powered medication, it can't be critical care. Well, guess what? The best thing for the patient may be that I decide not to give them TPA. So should I get less credit? Should I not be critical care because I was smart enough to know it's outside the 3-hour window, and I'm not so sure TPA is great for every stroke patient anyway, so I'm deciding not to do TPA. Can we still code it as critical care? It's a big controversy. I'm like, what? Of course it's critical care. Because you're giving assessment in order to prevent the further deterioration, which you don't want to cause. So you see my point. It's not the dramatic interventions that we do, it's the dramatic decisions that we make that we want to support in our documentation. That's where I want to get you credit. I call it the smart doctor, but I want to get you credit for the thought process that you go through to decide, I can manage this patient differently than with a big dramatic intervention. Okay? So that's all part of your process, frequent reassessments. And if we're doing them, we should reassert them. Now, I also suggest you document your re-exams on critical care patients. I think that's true. You saw the Dan Sullivan slide earlier. I think it's true on any patient you actually do a reassessment on. You got to mention it. Three reassessments showed, significant improvement in symptoms, or showed, the rate was 126, came down to 110, and settled at 75, and now okay to discharge. On my assessment, on my evaluation, okay, you get that from the nursing notes, but hey, if you went back in and checked, I want to know that increases the obvious work that you've done and the complexity of the chart. You just done more work. I want you to get credit for it. Okay, so this is what I was talking about, the ACEP coding course, where the consultants in the past have said the absence of manipulative and supportive interventions argue against the notion that critical care was actively provided. That has since been debunked. ACEP no longer holds that position. Now, what about critical care and other E&M services on the same day? Are there ever times when you see a patient while they're not critical, doing your normal evaluation and management, and then they crash? Never happen? Yeah, it's an emergency department. Of course it happens. Sometimes it happens the other way around too. They look like they're crashing. We're able to intervene, but now we've gotten them through their crisis, but now we have to make a disposition decision. That's going to take a little bit of time. Classic is the asthmatic. Okay, comes in, tripoding, this guy's all white, looks like he's not going to make it. He's like running out of gas here. He tried his meds at home and they weren't working. He's going to decompensate here shortly, and we're worried about him, right? So until you get him cleared, he's critical care. But now we're getting to the point where, okay, he's no longer critical care, but can I safely discharge him yet? That's going to take some more time, maybe a couple more interventions. That's actually a separate evaluation and management outside the critical care period. Now, CPT recognized that. That's what these statements actually say. Critical care and other E&Ms may be provided to the same patient, same day, by the same physician. And further, to be more specific, CPT all the way back in 1998, said an emergency department code may be reported in addition to critical care if both are provided by the same physician on the same day. Really? You can bill for both critical care and an emergency E&M? If you have done both at times when the patient was not critical, yes, you can report both. Now, this is not a common thing, as I described it. Often, the disposition decision is clear once the patient has been cleared through their critical care period. But the times when the patient looked fine, we're working them up and, take them down to x-ray and they go into VFib. And the crash cart comes out and it's all a dramatic thing. And you've done your evaluation. You've already done the level 5 workup. But now we're working the critical care piece. Now, it's not common, but they happen. CPT knows that and says, we would expect that you would report both an emergency department visit and a critical care service. Right here is the example right out of CPT where it says the two codes would be reported if critical care precedes the emergency department EM service on the same date. So the dramatic one is patients fine, then they crash. The not dramatic is patients looks like they're crashing. We solve that problem, and then we have to make a disposition decision with significant additional evaluation and management later. Those happen too. CPT says both of those would be separately reported. Well, Medicare doesn't like that. What we found is that when we bill both to Medicare and appeal it with a copy of the chart, most often we get paid for both the critical care and the evaluation and management. So it becomes a billing issue at that point because you'll get denials and you got to follow up with it. But Medicare will pay them. Now, I mentioned I'd like you to document your critical care time, even if it's less than 30 minutes, because your encounter with the patient may only be 20 minutes of critical care, but they hang around for a long time in the ED, it's shift change, somebody else takes over. Now the patient starts to go south again. I can take your critical care time and add it with the next provider on and put the two together and come up with a reportable amount of critical care. So there's value that way. There's also value that we show we don't always and only report, 30 minutes of critical care. I also want short times of critical care to support my claim for 99285. I've had audits where the payers, on first blush, the nurse reviewer looks at the chart and says, I'll give you the example. This is a dehydration patient, Medicare patient, severely dehydrated. She went into metabolic crisis. Her sodium was through the roof. She's a mess, but the doctor didn't document critical care, so we couldn't report it. We had to report it as level 5, right? Payer came along and said, oh, well, this patient really was just dehydrated, so what you should have done is just give her some fluids and send her back to the nursing home. Stroke of genius. Why didn't I think of that? But the patient, so just look at the labs. Patients, got like a sodium of like 180 or something. It's not sustainable. The medical review, the Medicare physician, the Medicare medical review officer, actually instructed his auditors in that meeting that had this chart have been documented in critical care, it would have been accurate. Coders, you missed the point. This really was a critical care case that didn't get documented as critical care. You should allow it as a 5, just on the face of the fact that the patient was critically ill. So documenting critical care time can kind of sometimes overcome the mistakes, the other mistakes that payers will make, even if you're not going to report it as 30 minutes of critical care. 15 to 20 will help the payer understand how sick the patient was. That's my point. Okay, that's just we can add times together. Another subtlety, reporting critical care before and after midnight. Not going to get into that. It's really kind of a coding issue. Now, how about critical cares on patients that go home? Does that happen? Well, here's right out of CPT Assistant. That's the official interpreting organ of the CPT. Gives the example of a 73-year-old comes to the emergency department with a rapid heart rate and a shortness of breath and diaphoresis. Gets a management to 45 minutes of critical care, assessing and treating the patient through breathing respiratory therapy, and completes the necessary history and physical, and subsequently determines the patient can return home. CPT recommends 99291, critical care, even though the patient was discharged. As I said, 5 to 8% of your critical care patients will be patients that you send home. These are all obvious patients in septic shock, respiratory failure, liver lack and a hematoma, cardiac arrest after a PE, significant hypovolemic shock. Those are obvious, Those are the rare cases. Our more common ones are patients who present with signs and symptoms consistent with these, but ultimately resolve without those, distressing final diagnoses. So payment is based on time, and we're going to aggregate the total time spent engaged in work related to the patient's management wherever it happens. 30 minutes, if it's less than 30 minutes, I'm going to bill the E&M only. If it's between 30 and 74, 99291, and I get paid incrementally above that. Now, we don't do critical care very often beyond the 74th minute, but it will happen from time to time. Those are 1 out of 100 or maybe not, maybe 1 out of 50. 2% of our critical care are going to get the 99292, where the case just took forever to clear them or to get them upstairs. So document our total time. The clock does start over at midnight, so I want to be able to add time on a particular day. Won't get into that. That's a coding subtlety. Other E&M. Now, what's included in critical care time? And you had alluded to it earlier. Reviewing test results and imaging, discussing with the medical staff, dialing for docs, trying to figure out who's going to cover this patient. Time spent documenting, horsing with Epic. That gets you critical care time. Obtaining history from the patient, other than the patient, talking to the family, treatment limitations, DNR, anything that bears on the management of the patient. All small increments of time that you aggregate in your estimate. What's not included is anything that happens outside the ED, like EMS medical command. Even if you're 2A interactive, it's technically not critical care because the patient's not immediately available to you. They're coming, probably. They're coming to your ED, but they're not immediately available. And then administrative duties and time providing other services. So here's some examples of critical care. These are all pretty solid. Once in a while you'll get patients will look like this and not be critical care. Some ones that pay attention to your hyperkalemics with bicarb treatment, hypernatremia with mental status changes, atrial fibs we've talked about. Not all of those, but most of them. If it requires aggressive management. If you hit them with one diltiazem and 20 minutes later they're fine, they spontaneously convert, you're probably not worried about them for 30 minutes. But plenty of atrial fibs don't respond that way. Other one, suicidal ideation, we talked about that one already. Clear and immediate threat requiring chemical or physical restraint, solid critical care. Some common meds that are indicative of critical care, we're loading them with Lovenox or Lopressor. Some of these we don't, haven't been around in a long time. If you're doing or even considering any of these, if you're thinking about putting them on BiPAP or CPAP, critical care is in play. If you've done any of these procedures, critical care is a solid consideration in that case. Now, I put this together as kind of a reminder because often I've had physicians tell me, well, I just don't think I'm doing 30 minutes. I'm doing 15, 20 maybe, but I just can't think that I ever really do 30 minutes of critical care. So I ask them to stop and ask themselves, okay, a certain number of my patients in every shift are going to be critical care. If you work a 10-hour shift and you see 2 patients an hour, you're going to see 20 patients. If your admit rate is 20%, out of those 20 patients, you're probably going to admit 4 of them. Okay? And I'll tell you that your critical care rate is probably going to be 35 to 40% of your admit rate. So that predicts that somewhere in those 20 patients, one of them at least was critical. So at the end of every shift, you ask yourself, which one was the critical care patient? Now, if you're working the red pod, I don't know how your ED is broken up, but if you're working the acute side, you're seeing all the 4s and 5s, right? So your admit rate's probably going to be 30, 35%. Now you ask yourself, which 2 or 3 of the patients I saw and treated today were critical care? Then you go back, just briefly, ask yourself, okay, these 3 guys, they probably were, I don't know if I spent 30 minutes. Then take something like this and just kind of mentally go down through it and say, okay, let's see. What did I do? Chart review, yeah, that was only 2-3 minutes. Document, yeah, it took me 7 or 8 minutes to finally get everything in the record. Med orders, that was another, we'll say that was 3. So I got 3 there, I got 8 there, I got 3 there, now I'm up to 14. Yeah, I went back and saw them 3 or 4 times, so let's call that another 4 minutes. So now I'm up to 18. Vital signs, we'll give a minute there, that's 19. Oh yeah, a lot of back and forth with the consultant on this patient. I know that I was either talking to the guy or chasing him for a full 10 minutes. Now I'm up to 28 minutes. And transfer of care orders, discharge planning, ordering, reviewing labs, interpreting x-rays and diagnostic studies, you got 30 minutes. So if you're having trouble getting there with the time statement, I just don't see how I'm spending that much time, do something like this. Also, if you're, I don't know if you get your statistics back, you might not, but just to improve your critical care reporting, ask yourself at the end of a normal shift in the normal ED, which of my 20 patients was the critical care one? Or, like I said, if you're working the acute side, okay, which 2 or 3 or however many, may actually be, but you saw at least 1, maybe 2, maybe 3, maybe 4. Who were they? Let me just think about them, and then I'll go back in and chart that note for those patients. Now, after a while, it'll become a lot more clear, a lot about how you're spending your time, how you and what the patients, what the indicators are of critical care. Things we used to not be able to bill with critical care, now we can. All this stuff is separately billable. Pacemaker, pericardiocentesis, chest tubes, arterial lines, CVP, CPR, all that pays additionally. These are codes that are bundled into critical care, meaning we would not bill the chest x-ray in addition to critical care. Cardiac output measurements, coders notice, those are not rhythm strips. Those are not EKGs. EKGs and rhythm strips are separately billable. It's a misconception in coding. It says cardiac output measurements, so somehow we think that includes EKGs and rhythm strips. The specific CPT codes are there. Those codes are not in that. And these are IV sticks, 3600, 36410, femoral draws. These are not, starting an arterial line or placing a central line, or those are separate. Those are different procedures. Okay, some chart examples. 55-year-old rapid irregular heartbeat, complains of palpitations, used in the doctor's office for a cold, and noted to have a fast heart rate. An EKG was done in the office and showed the rapid atrial fib. So the guy gets the EKG from the doctor and says, here, take this and go to the emergency department right now. The guy says, I was here for a cold. I feel dizzy, yeah, okay. And I get this every once in a while, it kind of comes and goes. But I'm not quite sure what the big deal is, doc, because it's like, I get it off and on. But this one's been going on since yesterday. I get it almost every day, and this one's been going on since yesterday. So okay, fine. Let me go to the emergency department. Fine, I will. So I like this chart because I like the ED course because it's very specific. It does paint a very clear picture of the aggressive management. And of course, he starts out, patient was aggressively treated here. We didn't stand around waiting for stuff to happen. We're right on this kind of patient. So he had a borderline pressure, so I got him a bolus of fluid, 10 mics of cardizem instead of the standard 20. So we're real patient specific with this dictation. The initial 12 lead prior to the cardizem showed the atrial fib with 164. He's got some PVCs. He tolerates the cardizem well. We watch him. His heart rate starts to come down, trending 90 to 120, and then we do the repeat EKG at 112. So, all right, good values. But then the rate starts going up. So now I got to put him on a drip. 10 mics an hour. He remains appropriate. Have him evaluated by cardiology. And then he has a short run of ETAC. So you can see the distress signals here, the potential distress signals, the issues that in emergency management of this patient we are concerned about, the immediate potential for life-threatening crisis. Okay, we're managing it well, we're on it, but this patient has the high probability of clinically significant deterioration. Even though it's not a new onset atrial fib. We've had it for a long time, but this one is really concerning. And so critical care clearly is in play, I think, with this patient. Do you have anybody that would not be comfortable coding critical care on this patient? Okay, I just have to ask because everybody's perception of what's the risk here is different. So to me, that's a rock solid critical care. There's a 49-year-old Caucasian female, severe chest pain, precordial. Tried her sublingual nitro at home, worked fine, but now she's coming in for the evaluation because it's not helping as much. She's got a concerning past medical, PTCA with an LAD stent. So, she's been down this road before. That's significant increased risk. But the real, so there's chest pain and then there's chest pain, right? There's plenty of chest pain that doesn't go to critical care. Get him a couple of sublingual nitros, 20 minutes later, it's pretty much resolved. We're not as worried about that patient, okay? But this one, we got him some sublingual, got him some nitro paste, half an hour later, she's still, the pain is progressively worse. This one causes concern, am I right? Higher risk for cardiac ischemia. So the didn't control the pain, and IV nitro begins. We get some morphine too with aspirin and Zofran, and that to me is a rock solid critical care. So here's an electronic record. I think this is, let me think for a second. I know where this came from. I think this is an Epic chart. It might not be. Severe upper back pain, short of breath after lifting heavy weights in the gym around 8 o'clock tonight. So guys here at 37 minutes after 8. So rushing right over from the gym. 24-year-old, short of breath, suddenly felt a sharp 10 on 10 upper back pain as he was lifting weights. Okay, so you know what happened. Right? So I got a spontaneous pneumo here. Goes into screaming pain, and so respiratory positive for shortness of breath. And now I like this record because it times the interventions. So this is real time. This is actually done by a scribe. And one of the values of scribe care is they can actually, if they're with you when they're doing it, they can actually scribe minute by minute. And this is really cool. I mean, it shows us what was going on at each step in the process. So we told him he had a tension pneumo. He agrees to the chest tube. We discussed the bleeding infection, possible failure of the procedure. Get him the Versed, cleaned and prepped at 2106. We can see after the procedure at 2100. We stitch it in place in 2106. He's feeling better. He appears less diaphoretic. This is just really obvious ongoing management. We document the pulse ox at 2109. Takes a deep breath. His pain is now 7 on 10. He's got some crackling and friction rub in the left lung, so we're looking for that. And then here's this, so we get what is a really good MDM note. Acute tension pneumo, and he describes it with critical care of 35 minutes. Everybody feel comfortable with that one? Anyone not feel comfortable with that one? Because the question isn't, were we able to manage it? Yeah, you know what to do with tension pneumos. They respond, right? But the question is, what if we did nothing? Same thing on the cardizem patient, on the atrial fib. Yeah, we manage those all the time. The question isn't, can we manage these patients? The question is, how about I take that patient, how about I take this guy out of the emergency department, right, and put him in the internist's office across the street and ask him, how comfortable are you managing that, doctor? Okay? Yeah, tell me exactly, how are you going to do that? Okay? It's like, oh my God, call 911, get him over the ER. So, just because we're comfortable doing something, it's because we do it all the time. We've got protocols and we've got process for this. But when we talk about intrinsic value of the care delivered, tremendous intrinsic value, and frankly value that many other specialties simply are not prepared to deliver. Okay, so we got to step up, own this. These are our patients. This is the work we do. Yes, it's not, granted it's not neurosurgery, but it sure has a life-saving effect. That if this patient doesn't show up in my ER, maybe goes somewhere else, I don't know whether he's going to get this kind of care. When he comes to my emergency department, we know how to deal with this stuff. And we can save this guy's, potentially save his life. So it's a hip fracture, but her mental status has changed dramatically. She has signs of an upper GI bleed, but it turns out that's not really the issue because critical care of 30 minutes necessary in order to treat the further deterioration, the need for frequent reassessments to the GI bleed, and the possibility of circulatory failure or CNS compromise. So, the patient has a upper GI bleed as well as a significant, so the significant hemorrhage is the GI bleed, right? So this is the issue with this patient. So critical care, clearly on that one. Here's an 89-year-old, comes from the nursing home. You see these patients all the time too, right? The nursing home dumps. They dump them in your emergency department. They don't know what to do with them. The patient's mental status changed. I don't know. She's not herself today. Okay. So she's holding her head down. She's 89, but she's holding her. This is not her normal state of health. Okay. Significant mental status change. So her extremities are limp. She's pressure in the 80 to 90 range. Pulse ox that's probably her baseline, but still, a concerning neurologic. She won't answer questions, doesn't move extremities purposefully. She's really out of it. And just like these weakened dizzies, often, not always, sometimes the labs come back fine, but so here you go. There's a sodium of 177. Just give her some fluid. She'll be fine. Dehydration, rule out sepsis. That really undersells it, quite frankly. Yeah, rule out sepsis, right. She may be septic. She also got a sodium incompatible with life. We kind of failed to mention that. But also, so the medical decision making is way too thin here. that is inappropriate. There is not a, there, he needs to interact with the labs. Obviously, if he had discussed the lab, I'm not as concerned that you go through and dictate, item by item, except that it will force you to interact with them. If that's what it takes to actually look at the labs and comment on them, then that's what you need to do. But all that stuff's brought in by, so you don't have to re-document it, brought into Epic. You just have to interact with it. Go through the labs and comment on the abnormals that are concerning, but the normals that are also either surprising or concerning. Okay, like that ABG where the pH, it's in the normal range, but the guy's respirations are 34, and he's been 34 for the last, several hours. He's trying to blow off his CO2, and he's going to crash. So, comment on the normals that aren't normal. Interact with the data is what I'm saying, which he didn't do. This is just an example for coders. Final diagnoses don't tell us whether or not the patient's critical. The only final diagnosis we can get here really is epistaxis. Turns out this lady's going to end up, practically bleeding out, because we're going to dictate about a page and a half of ED course. So we try all kind of stuff to try to stop the bleeding, the nosebleed. She's on Coumadin and a whole bunch of blood thinners and so forth. So we document and document and document. And finally, we have to hang blood in the ED and send her up to the ICU. So final diagnosis epistaxis, but she's critical care. Okay, questions about critical care reporting? Does it make sense? Okay, all right. So let's talk about observation care. Now, observation was built, it was really built by the payers for the payers. That is, they recognized that when you spend a significant amount of time with a patient where disposition is unclear, sometimes you can rule out the need for admission by simply hanging with the patient. Time is your diagnostic tool. When time is your principal diagnostic tool, observation is in play. Whether it's to determine the need for admission or the efficacy of treatment, OBS is in play. So OBS is always, billing for OBS has always been a problem, in part because in emergency medicine we can only bill for the ED visit or the OBS code, normally not both. So if I don't document it as OBS, I bill it as the ED visit. If I bill it as the ED visit, I can't bill observation in addition. So I got to bill one or the other. And we're comfortable with the ED code. We know how that works, the documentation for it. So normally we report that. But we're starting to see more and more observation care. Now, your OBS status, is that managed inpatient? Well, it's managed on the floor. It's managed elsewhere. Is that being done by hospitalists presently? It is. Okay. Okay. What hospitals have, I'm going to suggest this to you, but what hospitals have found over time is that hospitalists are not particularly good at managing CDU patients. They're good at managing observation care that lasts several days, but the people who are best at making quick decisions and disposition decisions are you guys. So more and more hospitals are turning to their emergency physicians saying, would you staff our CDU for us? Because we'd like to prevent readmissions. And frankly, the internists, the hospitalists, aren't as good at it as you are. Now, October 1, hospitals are going to start getting dinged for readmissions for CHF, COPD, and coders help me, is it pneumonia? Yeah, pneumonia is, okay. So there's going to be some significant money lost now by hospitals for readmissions within 30 days for those three conditions. Medicare will expand that. In a few years, they're going to look at it here, but they've already decided that they're going to save millions. The clinical literature is not clear about that in my mind, but at any rate, Medicare's putting it in, right? So these patients getting, these pneumonias that bounce back in 30 days, if it's really a matter of managing them for just 1 or 2, maybe a third day, load them with the meds and get them back out the door again. If you can do that without an admission, you will save the hospital not tens, but several $1,000s on denied readmissions during the post-admission, the 30-day post period. There are also, anyway, so emergency medicine, at some point in the future, hospital may be coming to you asking you to manage the CDU. That's never a moneymaker for us. Okay, it's a break-even or a loser to a certain extent, to the extent that you can't get the hospital to subsidize. We won't make money running an OBS unit. Okay, but what we can do right now is begin to document the observation care that we are doing, get the hospital some additional revenue already, and hospitals around the country are doing that more and more. Medicare utilization of OBS codes by emergency medicine was up 112% in the 3-year period from 2003 to 2006. I think now it's up 15% from 2008 to 2010. No, I'm sorry. ED OBS increased 15% for emergency physicians in a 2-year period. So more observation is happening. It does pay better than an emergency visit level. Okay, here's our emergency visit level. There's the observation care, that same day admit and discharge, different day admit and discharge. That's a coding issue that we'll deal with separately, but that's just to say that you can see the significant RVU difference works out to be something like 27 to 30% on average additional reimbursement for reporting OBS excuse me, versus critical care. So what kind of patients qualify? Lots of patients benefit from it. What kind of patients qualify? Well, yeah, go ahead.
So it seemed like what you were saying there is that we can do OBS, but that will preclude us from doing an E&M.
Right, great point. If you're not staffing a CDU, if you're staffing a CDU, it's a whole different issue. You're going to have different physicians managing that, or a physician in a mid-level. All right, so the physician is supervising the mid-level who's actually running the OBS unit. That's a separate discussion. But for your current situation, some number, I'm going to guess somewhere around 3 to 4% of your patients are going to get reportable observation care. They are right now. They are simply getting it. And when we begin documenting that, I will be billing for the OBS level, not the ED level.
So the OBS pays better?
Pays better, 30%.
30%.
Yeah, 30% more for observation care. Yeah. So yeah, so the patient benefits, but that's traditional OBS. Let's not go there. Okay, so who benefits? Atrial fibs, asthma, allergic reactions, all kind of abdominal pains, ischemic bowel, gallstones, kidney stones. Those are all classic examples. Flank pain and hematuria. And the one that isn't listed here, but maybe your most common OBS case, overdoses. How about the intoxicants? Got to clear them neurologically, right? Can't do that right away. Time is my principal diagnostic tool. I got to get the blood alcohol down before I can clear them neurologically. So time is my diagnostic tool here. Or the suspected overdose, they took some illicit drugs, or it was a medication mismanagement, and they took more of what they should have. Everybody responds differently, so what are we going to do? We're going to watch them. Those are all classic OBS. along with the ones that we've just mentioned. In terms of the fact that you're doing, time as a principal diagnostic tool. That's what makes OBS in play. If we had a separate OBS unit, we'd talk about that. We're not dealing with that. But here's some patients. Here's some examples from Medicare. An ED patient with difficulty breathing. A patient seen by the physician orders lab tests to help the patient and an injection to help the patient breathe more easily. Physician then puts the patient placed in an observation unit to determine whether this intervention produces normal breathing. 6 hours later, patient is seen again, who determines from the patient's chart or his or her own observation of the patient's vital signs that they are normal and the patient has resumed normal breathing. This is Medicare's description of an expected observation care in the emergency department. Now, we're a little more aggressive than this. I don't think we give them a medication and say, I'll see you in 6 hours. Okay? You know, I mean, you're back in to reassess them. And often you can get them out quicker than that. But hey, there are the patients that we give them an intervention and then another and then another, and they still don't clear, and now I got to watch them for several hours. 3-4 hours later, I'm now able to determine you're okay to go home. That, to me, is a more likely candidate of OBS than this one, because, you know, like I said, we just don't park patients. You know, give them one intervention and go back and see them 6 hours later. So that asthmatic that I just described is, for me, a classic observation care case. Medicare recognizes with an equivalent example. So here's a patient with that's a terrible example. That's a surgeon's example. Leaves orders for nursing staff to monitor the patient's condition and doesn't even go back in and see the patient. I have no idea how Medicare allowed that into the Medicare. This is right out of the Medicare manual as an allowed observation care. It really has to be an allowed observation for the facility, but it's listed as an example of a physician's observation care. It does not make sense to me, and I would not report that. But this patient complains of flank pain and hematuria. Classic. Do we see those? Is time our diagnostic tool? Often. Right, let's get them a couple hours, get them lots of fluids, and watch him for several hours, make sure we can control his pain. So we'll go back in and see him once or twice. But that's a classic OBS case. So other examples, kids with dehydration, flank pain and hematuria, asthmatics, abdominal pains, chest pains, substance abuse cases. All of those require, all that substance abuse stuff requires time as your principal diagnostic tool. Because even if the tox screen comes back clean, you're still going to be watching them. Time is my tool. Okay, so when is observation in play? Well, time has to be the principal diagnostic tool, not a matter of convenience. We're not waiting for somebody else to do something for this patient. Like, we've already discharged him, but nobody's come back from the nursing home to get this patient. So 10 hours later, she's still here, so I guess we're observing her. No, we're not. The disposition has been made. Decision is clear. It's a matter of convenience for somebody else. Psych. We call the psych team to come down and evaluate, get them upstairs. They get here when they get here. So 10 hours later, we're still, babysitting a psych patient. Are they observation at that point? No, unless they have some other medical condition that we are observing for. That does happen some number of times. But most of the time, it's just a matter of convenience, waiting for somebody else to do something. Waiting for the surgeon to come down, waiting for the contrast material to get through so I can do the contrast CT, which the surgeon wants, and wasting our time and everybody's time. But the surgeon says, I gotta have a contrast CT, and so we gotta park that patient for 4 hours while we wait for everything to. Time is not a diagnostic tool. if you had the CT result right now, would you be able to dispose? Now, some number of times the answer is going to be no, meaning it comes back, CT's negative, it's not a surgical belly, but the patient's still in writhing pain. And now what do we do? What are we going to do? Watch them. Exactly. Get them some meds maybe and watch them. So time is my diagnostic tool at that point. Admission or transfer is a real possibility, but not a foregone conclusion. Once I've made my disposition, the medical necessity of OBS has stopped. Okay. And finally, an order for OBS. And now if we had an OBS unit, I literally would need an order in the chart. Because I can't refer to OBS without an order referral to OBS. But instead of an OBS order in the chart, what we're going to do is effectively order ourselves to prospectively perform observation care as our diagnostic tool. Now the reason for that, the order concept, is to say, this isn't a convenience thing. This isn't we're looking back after and see we spent a lot of time, so let's call this observation. No. Because that's not how it's going to work on the cases that I'm describing. At some point in their ED encounter, you know that time is going to be your diagnostic tool. So it might be often it is, on exam. On exam on that patient that had a suspected overdose, took some kind of illicit drugs or whatever. Right away, they're not going home in the next hour or two, or probably even the next 3. Okay, because you're going to have to observe them. So observations are going to begin on exam. Other times, labs are going to come back. The CAT scan comes back and it's negative. And now, if it came back positive and I could get the patient upstairs, answer simple, let's go, move it. But now now they come back and it's diagnostic chaos again. Now OBS becomes my principal tool. That's 2 hours into the encounter. Okay, but I need to characterize it that way. I need the record to reflect that at some point observation became my preferred, and I use the term principal, diagnostic tool. Okay, if I had all the studies that I could get, is time still the thing that's going to tell me what I need to know? Okay. So, okay, go ahead.
With question to the time, is there a minimum requirement?
There is. The minimum requirement for admit and discharge, well, I'm not even going to go there. That's a coder issue. The minimum requirement is what was medically necessary to justify the time was significantly more than our normal emergency department encounter. Meaning, I'm going to get paid 30% more for managing this patient. I probably ought to be able to show that I did about 30% more additional work than the normal ED visit. So for me, that means a 4-hour time minimum. Because I want to show that observation isn't what happens in an hour and a half. That's our normal ED patient. I give them some meds, watch how they do, and if they respond, okay to go home. We do mini OBS all day long in the ED. OBS as a principal diagnostic tool happens when time is a significant component. So for me, the medical necessity threshold is 4 hours. But it's 4 hours from the time of encounter, not just from the time of beginning of OBS, but from the time of first encounter to the point of discharge. Okay, why? Because the time of first encounter, even though you didn't know it at the time, that's when your observation record began. Because now you're going to do your history and physical. That's your initial H&P, right? But I'm not going to bill that as an emergency visit level because I can't. So now I got to recharacterize what started out looking like an emergency evaluation and management. But after 2 hours in, that suddenly becomes, oh, that's my observation care H&P. So the work of OBS began back when you first saw the patient, became characterized as OBS, at some point in the ED encounter, at which I then performed medically necessary OBS to the total sum of at least 4 hours of management. Make sense? Now, what happens to the RVUs? Well, there are two sets of codes. Coders, if you're not familiar with the observation care, you may want to pay close attention to this. Have you been coding these at all in the ED before? No. Okay. All right. There are two sets of codes. The sets depend on whether we admitted and discharged on the same date. Date, not 24-hour period, sun up, sunrise, sun up, sundown, but date. 12 midnight is the difference. So a patient who gets admitted to OBS where the physician documents observation began at, that might be the time when I saw them at 8 p.m. All right, observation began at 8 p.m. Discharge from OBS at 2 a.m. I now have 2 different days. Okay? Admit and discharge different days. I use this set of codes. 99218, 219, 220. The emergency physician documents the comprehensive history, comprehensive exam, and high medical decision making, representing a 99220, and I get I code for on the day of admission at 8 p.m. I code 99220 for an RVU of 5.23, and on the day of discharge, the next day, I code 99217, observation discharge management, for an RVU value of 2.06. Okay, so for a combined RVU of 7.29. Now, if I discharge from OBS the same day as admit, patient comes in at 10 a.m., we begin observation and discharge them at 4 p.m. for a total OBS of 6 hours. I use this code set. Same exact content requirement, history comprehensive, exam comprehensive, medical decision making high, okay? But admit and discharge same day, I now get 6.23 RVUs. But I have to use this if I admit and discharge same day. Okay? So, physicians, we need to know, and hopefully Epic tells us, when did we see the patient? Because if you're documenting after your encounter, you need to state that, patient was seen at 12:10. Okay, because I want to start the clock at the appropriate time. And just, for throughput issues, you probably want to be paying attention to those things, because those are part of, what's the hospital? It's not an is that an HCAP throughput? Yeah, so hospitals are being measured on this stuff now for improvement. There are some 25 or 30 patient satisfaction components that the hospital gets reimbursed for measuring and achieving. And one of them is door-to-discharge time in the emergency department. So if you document that you saw the patient, you should get used to documenting what time you saw the patient because it plays into the whole HCAP thing. And, by the way, you can say, see, the problem is not me. The problem is not how long it takes me to get to see the patient. The problem is how long it takes a patient to get through triage, or how long from triage to the room. Those kinds of flow issues need to be managed. But the bottom line is we should get used to documenting time of exam. And it will make a reimbursement difference for observation care. There are now middle day OBS codes. So if observation goes over 3 days on 3 different dates, coders may choose, that's a patient that hangs around for several days before we're able to discharge them. Coders are able to report now middle day OBS codes. So that patient who hangs on for 5, 6 days in quote-unquote observation care. Will that happen? Yeah, once the hospital gets onto this readmissions thing with CHF and COPD and pneumonia, they're going to be asking you, potentially asking you to manage these patients in the emergency department, and you may end up inheriting them for days. In which case, you document whatever you did, and the coders will find it, and they have codes to report for those middle day services.
In terms of the order,
Yeah.
does it actually have to be a written order?
No, it does not. Not yet. Not
Time started at.
exactly. I'm gonna give you the phrase that pays in a minute. Okay. Go template it just like I did the critical care note. All right. So like remove all doubt for everybody about what's. But yeah, it's not a. Okay. Well, yeah. Let me just touch on that. Okay. So what do we have to have in the chart? I want to know what time we saw the patient. If there is an OBS order, that is, if we're asking the facility to bill OBS here in the ED, you'll have to actually write an order. Otherwise, you're effectively ordering yourself to begin OBS, and the way you do that is by invoking OBS at a particular time in the day. So, effectively, I began OBS at physical exam at 12:10 in order to determine, and I'll discuss that in a minute. But so we describe what time OBS began, because if I actually wrote a physical order, now nursing's got to like scurry around and do a whole bunch of stuff that they're going to come back and yell at you for. Because they're going to say, why do I have to, like I got to go back and look at the patient twice every hour, vital, there are protocols related to OBS that are throughput issues for emergency department nursing if they're not staffed to manage ED OBS. So if we actually physically write an order in the chart, or physically, you do it in Epic, but if you do an order, now nursing's got to do a whole bunch of stuff. So that's why we don't do that. The facility is not going to try and bill OBS at this point. They can. There is separate reimbursement for it, but that's a hospital coding issue. But from a professional component standpoint, we're going to say what time we're beginning our own OBS, and I'll show you how to do that in a minute. So we want a supporting note. So we want to describe OBS will be performed in order to. Re-exams are not mandatory, but you should document them when they're done. Reassessments are mandatory, meaning you actually have to have thought about that patient while they were through their OBS service. A discharge note is going to indicate what observation showed you. And finally, and this is the one thing that's different from your emergency department evaluation and management, is that you have to give a family history as well as a medical and a social. We know about the med and social. The family trips us up. So I'm going to actually have you write it in a different place, because you'll never remember to write it up in the family history section of Epic. So on my phrase that pays for the observation care note, what I'm going to suggest is you write your ED course and your medical decision making just like you've been taught. Okay, and you do it using the same process that you use right now. Then you add a observation care note. Okay, it's like a procedure note. But I'm now going to characterize the observation care that was covert in the ED course. I'm now going to pull it out and make it clear for everybody to recognize. And I'm going to do it with this templated process. So I'm going to start out, patient has or has no family history of X, because I know I'm going to forget it up there in the history section. All right? So I'm going to comment on the family history. Observation began at, you can tell me at the time of exam, at 12:10. Whenever was began at, when the labs came back at 14:20, whenever it was. Okay. I would also suggest, although I haven't formatted it this way, but that patient was seen at a particular time and observation begun at. That would probably even be a better way to set this up, because I really want to know what time the patient was seen in case OBS was begun later. Because remember, I'm starting my I'm pushing my OBS clock back to the time you first saw the patient, right? So observation began at and was necessary in order to determine. And I want you to use that language, because I want you to force yourself to say, well, was time actually the thing that was necessary in order to determine? Yes, it was. Okay, OBS is in play. And I want to punch up the importance of, I wanted to put it right out there, make it clear, time is what I was relying on here to make my disposition. Okay, because I'm going to show the value to the payer of the work I've done, but I want it to be clear, observation was necessary in order to determine, and then name what it is you're ruling out. Or the treatment decision in order to determine, whether they needed more aggressive management, or whether they could be safely discharged, or needed to be admitted, or to be transferred to tertiary care, whatever your decision matrix is. Tell me what OBS is going to show you. Upon reevaluation, we did see the patient. We're certainly going to see them before they go, I hope. So, upon reevaluation, observation revealed, not the CAT scan, not the second EKG, it's observation that revealed that the patient should be seen by cardiology tomorrow morning, admitted to the floor, admitted to the ICU. Now, that wouldn't be a good example because you're doing critical care, but whatever you're deciding, okay, it's OBS that showed me that I was able to safely discharge, and then the patient was discharged at what time. Okay, for a total observation care of X hours. So I've got my time, I've got my reason for OBS, my result of OBS. Okay, everything I need is in this effectively 2-sentence paragraph. Make sense? Okay, so let's take a couple of cases where OBS is covert, and we'll make it overt. Here's a 3.5-year-old found a baggie with at least one pill in it while playing in the front yard at the grandparents' house. Apparently it was not any of the parents' medications, so they looked at it and said to the kid, "Did you take any?" "Yes, I did." "No, I didn't." So grabbed the bag and the kid and off to the ER. Poison control is consulted. There's our case number. Recommended we give him charcoal, get him to drink voluntarily if he will. Does an initial EKG, and then of course they're told by poison control, watch him for 6 hours and do hourly blood sugar sticks. Okay, so we do the first one, it comes back at 300. Turns out he had sugar on his fingers, so we redid it and it was normal at 90. But we get the tox screen back on the tablet, and we're able to determine that the single tablet in the bag was morphine. Okay, so patient exhibits no signs of any toxidrome. He has, his repeat EKG shows this thing that kids get, this crazy flip T-waves thing. It's unusual, but not diagnostic. So anyway, the kid looks fine and okay to discharge. Now, observation is covert here. It is clearly what's in play. 6 hours of work. We're told that's what we're going to do. We're going to watch this child for 6 hours in the emergency department. So I'm going to dictate this. I think that's a perfectly fine ED course. And I'm going to then add my observation care note. So the patient has no significant family history. What's the family history relevance? Of a child, suspected drug ingestion. None. So no significant family history. Observation was begun at 11:15, necessary in order to determine whether he would experience toxic effects requiring admission. Upon reevaluation, observation and a second EKG in this case revealed that the patient could be discharged, which was done at 17:15 for a total of 6 hours of observation care. I have punched up the medical necessity, the value, and the performance of observation care, and done it in a 2-sentence note. Does it make sense? Fair? Yeah? Okay. Now, for Medicare patients, I need 8 hours of OBS for the same day admit and discharge codes. So if it's a Medicare patient who comes in at 10, gets OBS'd at 10, and goes home at 10 o'clock at night, I got 10 hours on one day, I can report that. OBS begins at 10 in the morning, goes home at 4 in the afternoon. I only have 6 hours of OBS. For Medicare, I can't report the same day code. I'll still bill the observation initial code 99220, but not the 217. In that case, I only get paid 10% more than a level 5, not 30, but I still get paid more. Okay. To bill the same day admit and discharge to Medicare, I require 8 hours of OBS. Now, that's not true if it goes past midnight. It's not entirely explainable. but the fact is that if that same patient was seen at 10 o'clock at night and OBS'd and discharged at 2 in the morning with only 4 hours of observation care, Medicare would pay the admission and the discharge, both same. Different dates of service, don't require 8 hours. It's an anomaly. That's all I can. There's a whole reason why this happened, but it doesn't make sense. So, okay, anyway. Clock starts back at the initial exam. We talked about that, so please document your time of exam. Okay, this is a good OBS chart. 69-year-old says she she's had approximately 2 weeks of feeling fatigued with shortness of breath. Notes the afternoon of presentation that she's had chest discomfort, a suffocating tightness feeling. She did have an episode of syncope. It recalls a couple hours in the afternoon of discomfort. There was some whole body tingling. We get into the system review. She's under a lot of stress because her granddaughter is graduating in Hawaii and she has a fear of flying 2,000 miles over the ocean. And she's thinking about it, and she's worrying about it. Oh my God, how am I going to do this? I don't know if I can do this. And it's going to be terrible. And she's talking herself into high stress. Do patients talk themselves into MIs? Yeah. Yeah. It happens. People can stress themselves out so much that, people are built differently. And patients can stress themselves into having an MI. Okay? So, don't know, but, she's got a history of depression. There's some stuff going on here. So, anyway. So, we do the EKG, chest x-ray, but then we make the patient observational at 11:25. For 6 hours to determine the need for admission, to repeat a troponin, since the patient has several hours of chest pain. Repeat troponin is negative. And after an observational period at this time of 6 hours and total stay of 8.5, patient appears reasonable candidate, discharged at 7 this morning. Now, I might argue, physician is a little wordy in his dictation, but he's built in the concepts of observation right into his ED course. So to me, that's a solid observation care case. So you have chest pain patients where you're doing, repeat enzymes. Time is your diagnostic tool there. And if it's taking 4 to 5 hours to clear those, I don't know how you do your chest pains. Do you do rapid assessments, or do you do the 4 or 5 hour troponins? Or
I do 2 hour rule out. So, but that's
2 hours.
The time at which I've gotten the initial labs, then
and then 2 hours after.
then
Right.
repeat the labs. So.
Right. So you might be able to get them out in 3 hours. Yeah, that's good. Okay. Different emergency departments have different philosophies about that.
So you're saying I could bill hours for that?
Well, with a total stay of only 3 hours, I think it might not be, we might not have done all the work expected of the observation care code. That's what I'm suggesting. Even though the case itself benefited from observation. Clearly, observation is the thing you did. Yeah, that's why you do the enzymes. It's, time, heart muscle and time, and kicking out the enzymes and so forth. So, It's just the total work of obs might not. Could I defend that? I think I could. I think I could make a strong argument that that's reasonable observation care. But if I got to pick a time frame somewhere so that I don't end up with, you know, trying to turn everything into obs that only takes me, well, if that one's 3 hours, how come this one also took me 3 hours? And that's all. That's all.
Does it matter, or does all the insurance companies follow the Medicare guidelines for time frames?
No, they're not required to, nor are you required. Well, yeah, but you're not required to observe them.
Well, no, but you had said initially too that some insurers just don't pay for ED-OBS.
Right, right. They don't. You have to appeal it.
Okay.
Now, normally when we appeal them, we get paid because they don't know what to do with it. Some of it is place of service issues. You know, you need a place of service 22 instead of 23 to get for some payers. Medicare is wised up to that. They don't have that issue anymore. They used to. Some payers want to see place of service 22 instead of 23. So, you know, you got this payer-specific, you know, issue going on to get it reimbursed.
So is it paying enough to make it worthwhile? All the
yes. Oh, that would be my point. That's why I've been talking about this for several years. Not just you guys, but I mean in terms of emergency medicine, and the specialty has come along. Like I started talking about this in 1998. It's now very common. You go to the ACEP reimbursement courses, they talk about coding now for observation care in the ED. It's a common component of what we do. So people recognize it. And like I said, insurers do reimburse for it. They don't understand it, and so they may deny up front, but when you appeal it with appropriate supporting documentation and you point out to them what observation revealed and what it prevented and here's the physician's statement and that kind of thing, we generally don't have problems. I'll get Medicaid programs, for instance, that will say we don't pay observation care in the ED period at all, ever. Okay, fine. I'm not going to build a Medicaid program for that. You know, but unless if I got a contract with a particular payer and the contract says we don't pay for observation care in the ED, all right, fine, I got a contract. But if I don't have a contract and it's, you know, it's United or it's Aetna or it's Cigna, and I don't have a contract that says I can't pay it, I'm billing it, and I'm going to pursue them until they pay it because it's a legitimate physician service. They should reimburse.
There's one thing I wasn't clear on. So you said, is it Medicare requires us to get to 8 hours before we can bill?
If the patient is admitted and discharged on the same day.
To the ER.
Right, right. Admitted to the ER and discharged from the ER same day.
Yeah. Then we have to get to 8 hours.
Then we have to get to 8 hours, Medicare only.
But not other insurers.
But not other insurers.
And what was the CPT code for initial observation?
Initial observation, if it's a different day discharge, is 99220, followed by 99217. Excuse me, 217 is the discharge code. See, there's two things in play. Think of it like an admission to the hospital, because that's really what drove observation initially, was let's prevent an admission to the hospital, but let's consider that you did all the work of an admission to the hospital, but you didn't admit to the hospital, right? So we're going to pay you almost as much, okay? So day one, I did an admission, but to OBS instead of the hospital, right? Then day 2, 3, 4, 5, somewhere down the road, I did a discharge. That's a separate day, that's a separate code. And for a long time, those codes were the only two that existed. Well, hey, what about the patient who gets admitted and discharged on the same day? I did all the same work, right? I admitted them in the morning, I watched them for 10 hours, and then I discharged them at 10 at night. How come I can't bill for both? So 5 years ago, 6 years ago, they created the admit and discharge same day code. Okay, but Medicare said, you guys will abuse it, so let's put 8 hours in there. That's basically the rule. Yeah. Let's just make you jump through some more hurdles to get to that code. Okay. So Yeah, it's a patient who gets observed, C-spine precautions after, there's a blood alcohol patient. So, you guy's got an elevated blood alcohol. Patient's observed extensively in the ED, gets the precautions while he metabolizes his alcohol, wakes up appropriate, able to ambulate. You know, we road test him around the department, has no other signs of trauma, and as the patient responds appropriately with a notable blood alcohol level is determined, a depressed level of consciousness was caused by the alcohol, and therefore patient discharged. Now, that's your classic drunk, you know, found lying on the beach in Laguna Beach, right? So we haul him into the ED, and literally you only carry the patient up the, it's 1 block from the beach to the hospital, so you can literally probably see the patient laying on the beach right there, and we haul him up the road to the hospital. And time does its thing. Patient metabolized the alcohol. Now I can clear him neurologically. That's what he said, no depressed loss of consciousness. And it was simply caused by the alcohol. So, okay to go home. Time is the only thing that could tell me that. So I'm saying, let's recharacterize this. With the patient has a non-contributory family history. OBS was begun after the exam at 1630 and was necessary in order to determine whether the patient would experience EKG or neuro changes requiring admission. Upon reevaluation, OBS and a second trauma screening revealed the patient could be discharged, which was done at 2230. So this note would supplement that very nice ED course and make OBS the reasonable choice. This is my last OBS chart. Good, we're right at time for break. 14-year-old smokes marijuana for the first time at 10 p.m. She's feeling weird, kind of out of it, mouth's dry, heart's pounding. Doesn't really like this. She and her older sister inhaled this joint together. Both were feeling bad, were home alone, and called the police. That shows you they weren't stoners, right? So this really is a first-time event. It's kind of benign, except that who knows what's in those joints these days. So what do? It's what we have to do, right? Okay, don't do that again, but here we're gonna, so yeah, we're gonna admit for OBS at 1 in the morning. Purpose was in order to monitor for further signs of toxic drugs. And after her stay, vital signs are appropriate. Alert and oriented at the time of discharge at 6. Intoxication of marijuana, no other evidence of serious intoxicant. So that's, to me, that's a rock solid observation care. It was medically necessary OBS. Okay. Questions or issues? Critical care and OBS?